Let's see what we can learn even from a paracenthesis. One might think that a paracenthesis is a simple and uneventful procedure. Same thing for inserting one trocar in the sclera. However, they might hinder a series of serious complications. Let's see the history of this male, 75 years old, with diabetic retinopathy, glaucoma with one drop in therapy, and central retinal vein occlusion in the left eye with mild macular edema. So the patient was treated with the injection of steroids in the vitreous chamber and partial PRP. Vision was 0.5, pressure was 18 with the drops in November 2019. So he cannot come for a few months due to the COVID time, and he comes back in June 2020 with neovascular glaucoma and erythema. I treat him with the washout of blood from the anterior chamber and injection of Avastin in the anterior chamber and intravitreal. So after this treatment, he comes back with a good-looking anterior chamber, and the pressure is high, 25 millimeters of mercury, and I can see a new hemorrhages that I actually consider part of this CRVO picture. 2 months later, he still has neovascular glaucoma, again erythema, vitreous hemorrhage, and the pressure is going up, even with maximal treatment for glaucoma. So I decide to treat him with vitrectomy, to complete PRP, injection of Lucentis, and air tamponade. This is how he appears 1 week after surgery. You can see the bubble of air on top, but most of all, you see an increase in intraretinal hemorrhages all around the posterior pole. So what happened? This is the OCT same day, confirming the presence of intraretinal hemorrhages. So to understand what happened, let's check the video. Well, you can see at the beginning of surgery, the cornea is edematous, the vitreous chamber is difficult to observe because of the blood in hiding the details of the iris. I insert one trocar, you can see fluid going out significantly, and then I insert the other trocars. This is a very common maneuver when I do pars plana vitrectomy. These are trocars 25 gene calipers. And then before inserting the infusion line, which I actually do most of the time, in this case, since the trocars are bulbed, I perform a paracenthesis in order to clean the anterior chamber to be able to view the vitreous chamber, because I already know that with the blood inside the anterior chamber, I would not be able to view the details behind the IOL, and most of all, I would not be able to view the right location of the infusion cannula. Then I wash the anterior chamber with injection of BSS and injection of viscoelastic to maintain the vitreous chamber clean. So now I can move into the vitreous chamber, which is hazy for the vitreous hemorrhage, and then performing vitrectomy, the vitreous chamber clears up, and I can see that there are hemorrhages around the optic nerve and signs of hypotony, so I increase the pressure inside the eye. Still, I cannot see very well, and I am forced to remove the epithelium in order to obtain enough view. So now the epithelium is removed, the blood is removed from the anterior chamber, and I'm finally able to move back to the vitreous chamber and see what happens on the retina. And when I do that, I actually find a surprise. But I don't realize at the beginning that there are these huge new fresh hemorrhages, and at first I interpret them as hemorrhages due to the CRVO. The patient is suffering from CRVO since a few months. So I move on with the vitrectomy. You can also see the view in the intraoperative OCT. After vitrectomy, I complete the laser where laser is missing in order to limit the ischemia that generated the neovascular glaucoma. Then I check again the completeness of vitrectomy by injecting triamcinolone. Surgery is then finished with a fluid exchange to maintain the pressure of the eye. So let's check again the view 1 week post-op. You see the bubble of air and the retinal hemorrhages, which actually, going back to surgery, I could see that they were there when I entered the eye. 1 month later, the hemorrhages seems to slowly disappear, but the pressure of the eye remains high. So I decide to implant an Ahmed valve and take care of the pressure. In fact, the pressure in November is now normal. The hemorrhages continue to reabsorb slowly, as confirmed even by the intraoperative OCT. But now let's try to understand what happened. So we faced the ocular decompression retinopathy. What is it? Well, it is the appearance of retinal hemorrhages following acute lowering of the intraocular pressure. The hemorrhages occur in all layers of the retina. Most of the patients are asymptomatic. They can be due to any surgical procedures in eye with high IOP, and they disappear spontaneously. So how to avoid ocular decompression retinopathy? Well, I think the best is never start a surgery with high pressure. Maybe I would say 30 millimeters of mercury, no more than that, or better lower. Use Diamox, mannitol, intravenous, and prepare the patient with a low intraocular pressure. So going back and looking at the mistake, I think the mistake was at the very beginning. So when I inserted the trocar, the valve was not valve enough, and so you could see the vitreous is exiting the eye very quickly, and the intraocular pressure is going down very quickly. And this is what caused the picture to change from one on the left to one on the right. And going even more back, when the patient received a few months later the paracenthesis, and then I observed those new hemorrhages, I think these new hemorrhages could be due to a mild form of ocular decompression retinopathy due to the paracenthesis, because I performed that when the patient had a very high IOP. We never stop making mistakes, we never stop learning. Let's hope this is for the best and to improve our skills and our knowledge on how to treat our patients.